Hello, everyone, and thank you for joining us today for our live educational webinar. Everyone's microphones are muted and cameras are turned off. So during the webinar, you may submit any questions via the Q&A button on your toolbar. We will take time then at the end of the presentation to answer those questions. Thank you. And now for our speaker, Dr. Christopher Merrick.
Hey, Mandy, thank you. I'm struggling with my camera. One moment here.
Yep.
There we go.
There we go. Perfect.
Okay, thanks, Mandy.
Hmm.
Well, thank you all for being here, and appreciate Electromed letting me talk about something that I'm really passionate about from a physiology standpoint all the way through to patient care, just because we see, especially my practice since COVID, I've seen so much bronchiectasis and chronic respiratory illness related issues with mucus clearance. So this topic has become very near and dear to my heart. So let's jump in. Today we want to talk about coughing, and it's just terribly common, as you all know, to see someone who has a cough. They could have that cough for any number of reasons. Patients, non-medical people, when they think of coughing, they think I'm coughing to get something out. And they are right. This is why we cough as humans, is to clear secretions from our airways. So someone can have a cough and can yet be absolutely packed full of secretions, and that can lead to downstream issues that can haunt them the rest of their life. And so the goal of today's talk is to empower anyone listening, whether you are in the pulmonary field or not in the pulmonary field, at any level or line of the medical field that you're in, to begin recognizing these patients, because I'm definitely coming to the conclusion in my own day-to-day practice that these individuals are everywhere and really underappreciated. So the arc of history is really, I think, such an interesting thing when it comes to medicine and when it comes to pulmonary disease. The field of pulmonology in the United States really grew out of tuberculosis and the chronic scourge that was. And then obviously 2020, this was a massive event for pulmonary medicine around the world. And we have these things in our history as a country, or really even in Western civilization, that you can point to and you could say, okay, this was really bad for lung health. But oftentimes when these things fade away, it's easy to lose track of the fact that lung disease can still be hiding. So tuberculosis was widespread, and especially here in Colorado, I'm based in Colorado Springs, we have a rich history of sanatoriums, and that was a lot of the founding fathers of Colorado Springs came out here for the clean air, and there were several sanatoriums built, now torn down. These individuals were forced into supine rest, and it was really a race against time before antibiotic therapy was rolled out to see if they could survive. Here would be a classic X-ray on your left of someone with an upper lobe infiltrate related to tuberculosis. And on the right side of the screen are just some typical accoutrement of treatment of TB at that time. And so this would be very standard technology for that point in time. These were these are now relics of healing and misery. So you see on your left, this is a pneumothorax apparatus. And then on the right, this is someone who's undergone a surgery called plombage, both creating a pneumothorax and doing plombage, where you put these spheres into the chest, where to decrease the oxygen tension within the lungs in hopes of starving out the infection and killing it. This was best understanding. This was best practice. This is what we did. Unfortunately, both the disease and the treatment led to extensive airway destruction. And so here are some sample radiographs of individuals who have bronchiectasis and lots of parenchymal distortion related to both their infection and the treatment thereof. So bronchiectasis is really the linchpin of our conversation today, even though I won't necessarily spend a lot of time focusing on it. Bronchiectasis is a condition that the public, I would say, probably isn't really aware of. All of our patients have bronchitis or have heard of bronchitis or asthma, but very few individuals have heard of bronchiectasis, even if they haven't. So bronchiectasis arises from this cascade and cycle of inflammation, infection, damaged cell wall, and increased mucus burden. These individuals get, as you can see, both in the anatomic cross-section and in the CT cross-section, lots of destruction, and because of the destruction, they get dilatation, they get an enlargement in the size of that airway. That airway that once had a really nicely functioning ciliary elevator moving secretions up and out is no longer able to do that. And when this individual coughs, and they're going to be coughing a lot, they're unable to clear those secretions. And so you get ongoing cascading of this cycle: inflammation, increased mucus, damaged cell wall, round and round we go. In the early 1900s, better techniques became available than giving people pneumothoraces, et cetera, for treatment of chronic lung disease. So this would be an early model of IPPB, and it's coupled with airway clearance. The thing that I like about this, just as a aside, the Monaghan pediatric vent-lung makes therapy fun. Having the same feature as the adult model, even children who are afraid of therapy can be coaxed into using this because of the face like a friendly clown and an eye that rolls. That sounds like a terrifying device. So anyways, that's just an aside. Thankfully, we don't have that anymore. I don't think we do. Here would be a picture of someone doing postural drainage. This would be a pretty extreme example, but people did this because it works. You get the secretions out because they're predominantly in the bases of the lungs. You hang upside down, those secretions can work themselves out. Here was a real development in my mind in the history of treatment of pulmonary disease. This was in 1915. In soldiers with thoracic injury, Dr. McMahon showed that based on his large experience of chest cases, how very important it is where there is serious lung collapse and chest deformity, like following wounds or illness, breathing and physical exercise should be given as accessory to medical and surgical treatment if the best possible recovery is to be assured. Already, this understanding of fully aerating the lungs, moving secretions, and this was an early understanding of how key movement and just the mechanical impact is. Historically, in the history of the world, people didn't live long because of war, disease, and famine. And so we didn't have to worry so much about these types of things. And so this was a 16th century painting, The Triumph of Death. And although death still ultimately does triumph, we are seeing people live much longer. And that's where a lot of this comes from. So the common enemy of time, I think, is the thing that brings us together in terms of scope of practice. It doesn't matter what field you're in of medicine, we're all seeing patients getting older and then dealing with different things throughout their lifetime. And then there's obviously the difference between physiologic age and chronologic age in terms of smoking history, exercise history, overall health history. And so you see this significant increase in life expectancy here in the United States from the late 1950s on forward. As we age, there's a normal loss of muscle mass over time with aging. These are two graphs pulled from a paper that deals with the topic we're going to discuss called sarcopenia. Sarco meaning muscle, penia meaning lack thereof. Total muscle mass in men and women is what's portrayed here. ASM is appendicular muscle mass, but essentially that's getting at all the muscle mass incorporated from the shoulders and the hips down. Shoulders out and hips down. And over time, that decrease is really noticeable for men. That's likely due to lack of testosterone, less exercise over time, et cetera. But women also have an obvious loss of muscle mass over time. As a pulmonologist, we don't generally think about muscle mass, but I want to make a case today that it's very important in management of chronic lung disease. There's a really interesting paper that came out of Japan in 2023 that'll base a lot of this discussion off of, that looks at respiratory sarcopenia. And so you see this dynamic interplay between chronic lung disease like COPD as it interacts with aging, malnutrition, low activity. And that can lead to both whole body sarcopenia, lack of muscle, and respiratory sarcopenia, or lack of muscle in the respiratory system, which would include the diaphragm and the chest wall, and its effect on breathing. Stick with me here through this flow diagram. Low respiratory muscle strength in the top left can be evaluated with MIP or MEP, maximal inspiratory and maximal expiratory pressure. And if that is low, then that's going to lead you down this path of low respiratory muscle mass on CAT scan or ultrasound. However, we don't always have ability to test a MIP and a MEP. So if it's difficult to measure respiratory muscle mass, then we can go to low appendicular skeletal muscle mass. If they have that, then they're very likely to have respiratory sarcopenia. If they don't have low appendicular muscle mass, then they possibly could have it. The fact of the matter is, what I'm getting at with this is we don't have to do extensive testing to understand whether or not someone is at risk for a weak cough or respiratory sarcopenia. So here's a summary of different things you could do in your clinic: maximal mouth pressure, peak cough flow, peak expiratory flow rate. All of these things, they've got it graded here by accuracy and simplicity. But the fact of the matter is, you don't have to dig into that to have an understanding of what's going on. Forgive this busy slide, but I want to pull out a few specific things. I need to move my box here. In number 2, the hand grip strength, knee extension muscle strength, gait speed, chair rise, and one leg stand time are significantly lower in individuals with sarcopenia as opposed to what we would call robust people. Independence of ADLs was significantly lower in the respiratory sarcopenia group. And then in terms of prognosis, risk factors for developing pneumonia in older people included respiratory muscle weakness, decreased trunk muscle mass, and malnutrition. Respiratory muscle weakness is associated with an increased risk of mortality in older people. Something we see a lot of in the hospital is respiratory muscle weakness, and we see that that is associated with an increased risk of reintubation and need for tracheostomy. So again, sarcopenia affects every part of our existence as humans, not just the respiratory side, but the respiratory side can really drive a lot of chronic comorbidities for these folks. So you have the immense benefit and pleasure of looking at my artwork. So this is what I use to teach medical students. So I've tried to recreate it here. So let's see. So again, coughing is a dynamic process. So as we look at the respiratory, at the airways, and then at the lungs, we have the diaphragm and then the chest wall. These are used to create a cough. In order to create a cough, we have a deep inhalation, which is an extending down of the diaphragm and an extending out of the chest wall, and then a rapid collapse of the chest wall and collapse of the diaphragm for a forced exhalation, or a huff cough, as some of you might know. This creates airflow, which clears things out of the lower lobes. If we have a blunting of that respiratory muscle, say if you have someone with a paralyzed diaphragm or ALS or something like that, then it's very easy to get buildup of secretions and mucus burden in the lower lobes. This can lead to bronchiectasis, which is airway inflammation, recurrent infection. And we see this in specific disease states like ALS, spinal cord injury, chronic weakness of anything, and old age. We also can see it in aspiration, which is kind of obscured here. All of these things, when you take it together, this individual can be defined as frail. Well, if you have frailty plus a recurrent infection, you need to ask a question of what is going on. You need to start digging a little deeper into how to manage this person appropriately. So I want to give you kind of our process of managing these patients here in Colorado Springs. Whenever we have someone with weakness, and again, if we see that they have difficulty standing from a seated position, weak grip strength, especially we start thinking about this in individuals over 65 years old. If they're underweight, actually, that would be more risky than overweight, generally speaking. That's predominantly due to malnourishment. And this is really common in Colorado. If they've been hospitalized for any cause in the past year, what we see a lot of is you go in for a knee arthroplasty or some non-pulmonary thing and you come out hypoxic, and then you're just going to be weak. If you already have these elements of frailty, having any hospitalization is going to put you at significantly increased risk for respiratory complications. So if you have any of these facets of frailty, you need to start paying attention. If you have any of these respiratory frailty issues, plus a recurrent pulmonary infection, then you really need to start thinking, could my patient have bronchiectasis? The next step here would be to get a CT of the chest. I suppose high resolution CT would probably be the best, but really any CT is going to show us if they have an infiltrate atelectasis and or bronchiectasis. At this point, this would, if you're not practicing in the pulmonary world, this would prompt a consult to a pulmonologist. But you don't have to wait for a pulmonologist to see your patient. The arsenal here is multifaceted. A nutrition consult for people who are underweight, especially elderly, depressed people who aren't eating. Speech and language pathology consult to evaluate for aspiration. Exercise, dating back to 1915 with the doctor taking care of soldiers. We've had an understanding for a century how important this is, but still it's very hard to get patients to do it. Flutter valve is always a good start. It's a cheap alternative to digging in deeper. Incentive spirometry, 99% of our patients will leave the hospital with this. And then high frequency chest wall oscillation, also known as HFCWO, or just plain old vest therapy. Vest therapy historically was stationary units, but now is much more mobile for patients. It's something that I use a ton of in my clinic. In my practice, I started out doing just a lot of flutter valves, aerobicas, which are great, but I found that patients generally lack the discipline to be using those things 10 times an hour like they're told to. And so what I have found is I've had a lot of success getting people started on vest therapy and just telling them you've got to do this twice a day. And then many of my patients have significant improvement. And then when they are in a phase of stability, they can oftentimes drop down to once a day on their vest therapy. The vest can be used by itself, but generally would be used with a bronchodilators like an albuterol nebulizer or nebulization, and then a hypertonic saline neb, which is going to help thin out that mucus burden and serve as what we call a mucolytic. This results in significant improvement in mucus clearance by mobilizing the mucus into the proximal airways for easier cough clearance. So again, going back to the sketch, as someone's fully inhaling their lungs and then collapsing down their musculature to get a good cough, if you've got bronchiectasis, that airway is going to oftentimes snapshot on itself, and you're going to get a increasing mucus burden due to plugging into the distal airways. This is going to be, using the vest is going to be when people aren't actively coughing. Generally, they're not actively coughing. And it's going to oscillate, as it's oscillating in the chest, is going to move those secretions into the more proximal airways in order so that next time the patient coughs, it'll be in a proximal airway and they can get it up and out. So I'd like to summarize, and then we'll have some time for questions. In the history of the world, people died at a much younger age due to famine, war, and disease. We've had obvious epidemics and pandemics of pulmonary disease, both in our country and around the world. And at that time, it'd be easier for medical providers to be keeping an eye out for those things. However, now, due to an aging population and the basically inevitable development of respiratory sarcopenia, it's not that everyone that gets old and that everyone is weak needs vest therapy or any type of pulmonary clearance therapy, but you've got to keep your head on a swivel in order to catch these patients because it is so common out there. And so whenever you see someone who has weakness of muscles, difficulty standing from a chair, difficult grip strength, and if they're experiencing recurrent pulmonary infections, the first thing you need to start thinking of is insufficient cough, insufficient mucus clearance, and the potential for bronchiectasis. So with that, Mandy, I'll turn it back over to you. I appreciate everyone listening.
Thank you so much. I especially loved your drawing.
Thank you.
We do have a couple of questions that have come in. How do you manage airway clearance therapy for your frail patients?
For me, oftentimes nowadays, I'll begin jumping directly to vest therapy. Again, it's just so difficult to convince people of the importance of using their aerobica or their flutter valve. Patients just really don't buy it, or even if they do, it's just really hard for them. So I'll oftentimes start with vest therapy, and I'll usually add at least albuterol. A lot of my patients, they have difficulty tolerating the nebulized saline. And then I really push exercise, pulmonary rehab, and good nourishment and good nutrition.
And do you have a time frame, or how long do you usually wait to move to HFCWO?
My time frame is definitely tightened up. I would say historically, I would wait until they've had 2 or 3 exacerbations. I think if I start getting to them sooner with this, that would probably delay that. But oftentimes that's the prompt, even as a pulmonologist, even if someone who's passionate about bronchiectasis, oftentimes I wait until they've had several exacerbations. I would probably start turning that down to 1 exacerbation in a year. You need to really start thinking about some sort of clearance therapy. And again, what I lean toward is vest therapy.
Let's see. What do you think we'll start seeing post-COVID and the prevalence of bronchiectasis?
Yeah, so after 2020 and in 2021, Mandy, and I'm sorry, I don't know what you're seeing. I think I've totally screwed up the screen.
Just that. That's okay.
I saw so many individuals with bronchiectasis, severe pulmonary fibrosis, and what has thankfully come of those people is the ones who survived their hospitalization have generally done fairly well, and most of them would fall into, this is my practice, most of them fall into what I would call dry bronchiectasis, so I'm not really seeing them exacerbating. Most of them were healthy prior to getting really sick, and so they've returned to pretty good exercise, pretty good nutrition, etc. So it's been less stark than I thought it would be, but certainly early on saw lots of issues with new onset fibrotic lung disease and bronchiectasis.
Why do you think bronchiectasis is so underdiagnosed?
I think it's just esoteric enough. Patients aren't asking about it. I mean, the number of times I get asked about different medical treatments or devices is generally related to ad campaigns of device companies, drug companies. That's really how patients come across this, or if they Dr. Google things. But if a patient sits at home, let's say they search cough, mucus production, I mean, Google is probably going to spit out bronchitis and asthma. So I think bronchiectasis has to really be at the forefront of our mind as medical providers, because patients aren't really coming in saying, hey, doc, do you think I have bronchiectasis? And we all get busy. We all get stuck in our mental ruts. And so I think keeping it top of mind for me has been really important.
Mm-hmm. And do you have any suggestion on how we can move the needle with that?
I think really good screening programs for weakness. I think again, I've started to incorporate that even into my specialty practice as a pulmonologist. It's people just want to come in and talk about their inhalers or whatever. But for me, it's really helped to look at the whole person. And this is not meant to be cheesy, but truly look at the whole person, because these issues of weakness really affect every facet of someone's life, from falls to, which could result hip fracture, early death, PE. And so starting with an assessment of someone's strength, and that can be done, what I liked about this paper that I showed, that can be done very easily. You can, in 30 seconds, you can have someone do 3 sit to stands where they would sit in a chair and stand up. Okay, can you do that unassisted? Can you do that without pushing on the rails of the chair? Okay, great. You could have them squeeze your hand. And if they're really having difficulty, and the sit to stands can be a real difficult thing for our aging population, those are people that you at least need to be watching out for. Are they having recurrent respiratory events? If they're not, great. But oftentimes we'll see this after this elderly individual goes into the hospital for something unrelated, comes out, and now they've got respiratory things because they were cooped up in a bed, they've got atelectasis, they've got increased mucus burden, they feel poorly, they're in pain because they had an appendectomy. All these things build up and affect the lungs.
Mhm. Looks like we have one last question. Has COVID created more bronchiectasis, do you think?
I think it certainly has. Again, and I don't claim to understand it, but my general observation is my post-COVID fibrotics are generally what I would, and I didn't really get into at least my definitions for this, but they're generally dry bronchiectasis. They're not bringing up a lot of mucus. Their weight is good, but I think that certainly COVID did contribute to early development or early progression of lung disease in people who otherwise wouldn't have experienced it.
Sure. All right. Well, that is it for questions. Any last words, Dr. Merrick?
No, again, I just thank you for the opportunity, Mandy, and I really appreciate everyone being on. And my hope going forward from here is that you would keep in mind, first and foremost, screening for weak patients. And if you have a weak patient, you need to think about a weak diaphragm. If you have a weak diaphragm, you need to think about the risk of recurrent pulmonary infections, which can be very deadly over time. So with that, nothing else. I appreciate
All
everyone.
right. Well, thank you so much, Dr. Merrick, and thank you to everyone for joining us. Make sure to contact your clinical area manager if you do have additional questions. And thank you, everyone, and have a great day. All right. Thank you.
Bye, Mandy.
Bye.